meeting to order, please.
Great. I will note that Commissioners Gerardo and Chung are here. We can move on to item 2, which is the approval of the April 20th minutes. And Commissioner, I just emailed out the data that you reminded me to follow up on from Commissioner Christian's request. That's in the minutes.
Great. Yeah, I just received it, and I really appreciated that demographic data. So thank you for getting all that information to us.
Sure. So,
and I'd like to make a motion to adopt the minutes.
I second.
Great. Well, with 2 of you, that's all we need. Thank you very much. The item passes. And there's no one on the public comment line, just for you all to know, at the moment anyway, so there's no public comment. We can move on to item 3, which is the maternal, child, and adolescent health fiscal year 2021 update on public health nurse home visiting programs and intimate partner violence assessments. We've got Ms. Vasquez and Ms. Armstrong.
Hi, thank you very much. Good afternoon, Commissioners. Good afternoon, Mark, and thank you for having us. My name is Maya Vasquez. I'm the nurse manager for the Field Public Health Nursing and the Nurse Family Partnership programs. Aileen Armstrong, our MCAH director, is also here. I will give the majority of the presentation, but she's also going to give a little information as we move through. Is that okay that I get started?
Yes, please.
Great. Okay, so if you could go to the next slide. Okay, so I manage 2 public health nurse home visiting programs, as I mentioned. We see these as sister programs, and we carry about 480 clients or more at a time. And excuse me, I should have said families. We provide intensive case management, medical and social assessments and interventions. Our work is prolonged and it's very relationship based, and there's a high level of trust that's developed between clients and PHNs, which actually becomes very important as we move into speaking about IPV. And just for a breakdown, Nurse Family Partnership currently has 282 open cases, that is open families, and our field team has 199 open cases. We have 2 nursing vacancies, 2 new staff who aren't taking clients yet, and we have 3 who've recently returned from COVID deployment, and so they're building their caseload. So that number will grow as our staffing improves. Next slide, please. People ask what public health nurses do, and it's because it's not as clear cut as many RN positions. So PHNs hold a certification in public health, and we work to increase family resilience through supporting responsive relationships between child and caregiver, through reducing sources of stress, including medical, social, and economic stress. We work to strengthen core life skills, including education and jobs, with a goal of supporting children to have healthy development and increase their educational achievement, and with a goal of supporting their caretakers to be responsive caregivers, as well as promote their economic and social stability. Next slide, please. So I'm going to speak individually about each of these 2 programs. The Nurse Family Partnership is an evidence-based national program. Our PHNs receive advanced training in motivational interviewing, maternal role development, infant and child development. In order to be eligible for the Nurse Family Partnership, a first-time pregnant person needs to enroll by 28 weeks gestation, and then that person will be enrolled in our program until the child's 2nd birthday. San Francisco has also been participating in a pilot to enroll multiparous, or people that have had more than 1 child already, pregnant people. We visit between 1 and 4 times a month, and that's very much based on client need as well as where they are in their pregnancy or postpartum journey, with more frequent visits at the end of pregnancy and during early infancy. The focus is client-centered, meaning the nurse adapts the curriculum to ensure it's relevant and valued by the client, with a focus on each client's individual needs. It's relational, meaning that the relationship between the caregiver and the PHN is a primary tool for learning and growth. It's strengths-based, meaning it's grounded in adult learning and behavior change theory. and it's multidimensional, meaning that the PHN takes a holistic view of the client, including family and community environment, the family's race and ethnicity, and the life course development of the family. We, in NFP, if we're fully staffed, we have 14 nurse home visitors plus 2 charge nurses. And to give you an idea of how many clients we serve in 2019, which was the most recent sort of normal year, we served 540 clients from 316 families. Next slide. So nurse-family partnership has been involved in randomized controls trials since its inception at least 3 decades ago, and we've seen significant reduction in pregnancy-induced hypertension, preterm births, child abuse and neglect, ER visits, behavioral and intellectual problems when the child reaches 6, and arrest of children by the time they're 15. Next slide, please. So our second program is our Field Public Health Home Visiting program. And this is an evidence-informed community health program that focuses on improving maternal and child health. We serve historically marginalized low-income pregnant people until the child is between 6 and 12 months, then that sort of depends on what the parents want and where they're at in terms of reaching their goals. As well as we also do serve smaller numbers of postpartum people and pediatric clients. We previously served many more postpartum clients. That was the bulk of our work. But in recognition of the large body of evidence that indicates that early intervention leads to improved health outcomes, we've done a considerable amount of quality improvement work over the last 5 years to change our focus to really enroll clients during pregnancy and to try and improve our outcomes. Similar to NFP, visits are 1 to 4 times a month based on client need. The focus is, again, client-centered, relational, and strengths-based. We have, when fully staffed, we have 11 nurse home visitors as well as 2 charge nurses. And in 2019, we served 855 clients from 451 families. Next slide, please. So the field nursing program is now participating and planning for a pilot that will begin in July of this year. And this is part of a multi-county partnership between San Francisco, Napa, and Sonoma. It's called the Trauma Informed Approach Public Health Nursing Program. UCSF is our evaluator for this pilot, and we were awarded a California Home Visiting Program Innovation Grant of $3 million over 3 years for this program. Next slide. So the model objectives for TIA-PHN are to support low-income families who are at high risk for trauma, either historical or current, and are experiencing medical or social challenges through the use of trauma-informed ACEs, or acute childhood experiences, education in a self-reflective approach to mitigate toxic stress, build resilience, and optimize health. This will include preferential enrollment in pregnancy, 1 to 4 visits a month. We will be engaging the clients in conversations about acute childhood experiences. I'm sure you're aware that there is an ACEs questionnaire. We will offer that to the client. It is up to them if they choose to complete it. And it's also up to them to choose whether or not they share the information with the nurse. But we know that this will spawn a lot of conversation. We're going to be providing education around 6 components of resilience building, including sleep, nutrition, exercise, relationships, mental health, and mindfulness, and the effects of all of those on family wellness and child development. This is client-centered and relationship-based, and the clients will be enrolled until the PHN and the parents agree that the goals are met. So it's flexible in its timeline. This intervention, I know there was a question around language. This will be provided in any language. We have access to interpreter services via telephone. In San Francisco, we also have bilingual nurses who speak Spanish, Cantonese, Tagalog, and Arabic. So we can provide care in those. And then in terms of target numbers, there will be 50 clients enrolled per county this year. in 2021, and then for the 2 following years, it will be 100 clients per county, and that's at a minimum. In San Francisco, we're a larger team than the other 2 counties, and we anticipate enrolling larger numbers than that. Next slide, please. So I'm going to move now, sort of having given you a broad overview of what our programs do, and really centering the sort of the long-term and the relationship-based work that we do. We want to move into talking about domestic violence or intimate partner violence. And this slide comes from, this graph comes from the Family Violence in San Francisco 2018-2019 report, and that's from the Family Violence Council. In that report, they use domestic violence as opposed to intimate partner violence, and so that's why I've kept that language here. If you look at this graph, you'll see the darker orange represents the percent by race ethnicity of the San Francisco population, and in the orange bars represent the 2019 total victims of domestic violence as reported to the San Francisco Police Department. And so just to think back to our programs, you can see here that Black and Latinx families are are disproportionately affected by this. And if so, thinking about our clients, 22% of our clients are Black, where only 5% of the San Francisco population is Black, and 52% are Latinx, as compared to 15% of the population. So we are serving clients who are more likely to be affected by domestic violence. Next slide, please. In terms of domestic violence homicides with female victims, we reached out to our epidemiologist, Jody Stuckey. Unfortunately, she's been deployed to COVID work for the last year, and so has not been able to do the types of yearly analyses that she usually does. But what she did say to us was that in the last 10 years, only 1 pregnant woman has been murdered because of intimate partner violence. And then the other thing to think, and you can see on this graph that San Francisco homicides have decreased over the last 30 years, although they're not as low as we would like them to be. And if we're thinking about emergency room admits for injuries resulting from assault due to IPV, and this is looking at female victims again, so we're not speaking about everybody, we're speaking about female victims. If we look at, we do not have the numbers for perinatal clients, but we do have numbers for women between the age of 15 and 44. The Healthy People 2020 objective is to reduce the rate to no more than 461 per 100,000. The California rate in 2017 was 399.8, so basically 400 per 100,000. And the San Francisco rate that same year was 491. So San Francisco about in line with Healthy People objectives in 2017, but higher than California overall. Next slide, please. So in our public health nursing programs, we screen our clients for IPV in the first 1 to 2 visits. But we're very aware that clients often don't disclose then, and we frequently circle back to this question later on as the relationship builds between the client and the parent. All of our clients, all of our PHNs have received training from Women Inc. and La Casa de las Madres around screening, risk, and safety planning. And we also use those 2 places as referral sources for their hotlines. In 2020, with the onset of COVID and as we moved into telehealth, primarily telehealth work, we did institute recommendations. I apologize for misspelling Dr. Kimberg's first name here, but LEAP SF and Dr. Lee Kimberg had recommendations around screening with telehealth. And then safety planning just consistently includes thinking about creating a go bag that includes money, credit cards, and other essentials, thinking about how to keep your cell phone and your cell phone data safe, and then planning for a safe place to go to, because many times people aren't ready to leave. Next slide, please. So these are some of the tools that we use. On the left is a brochure that is created by LEAP around safety planning. This isn't available in English, Spanish, and Chinese. And it has, and we use it both in our home visiting programs as well as our Black Infant Health Program uses it. On the right is an IPV assessment used by the Nurse Family Partnership. This is available in English and Spanish, and then for other languages, the PHN or the interpreter will translate it. Next slide, please. So our other MCH programs are working also to screen for intimate partner violence, including the Black Infant Health Program, our California Perinatal Services Program, which works to improve quality prenatal care throughout all of our prenatal clinics. And then we're also partnering with Sister Web of San Francisco for improved doula access for BIPOC families, and they also screen. Aileen, do you have anything you wanted to add here?
Yes, thank you, Maya, for the presentation, and good afternoon, commissioners, and thank you for this opportunity for us to present today. So I would like to make sure with this slide is that making sure that we have a universal screening tool assessment when interviewing our clients to ensure that we have a safety plan and for resources to be available at the time of screening if there's a need. And another goal plan is to adapt the Department of Behavioral Health, their 3 vital signs, where all of our MCH programs are screening for substance use, depression, and also intimate partner violence. And currently, we are limited with access to data reporting around IPV because we do not have access to our Department of Public Health electronic records, EPIC. We haven't went live yet, but once we go live with EPIC, we'll have the opportunity to obtain data and get more access to the number of IPVs that are reported, so that we look forward to going live soon towards the end of the year. However, once we have access to that data, we'll be able to pull, we can be able to run reports. And then also, this will give us more concrete information regarding this sensitive issue that we're working with our clients. And we look forward to continue to build capacity and seeking more resources for our pregnant and postpartum people experiencing IPV. So next slide. So I really wanted to highlight here because I'm proud to say that MCH have a new leadership that we've hired our new MCH coordinator, Jenny Lopez, who oversees a number of our MCH programs. And we also will be bringing on Dr. Zaya Malawa, who will be our new perinatal equity medical director to assist with providing consultation to many of our perinatal equity programs, as well as bringing about alignment with other key stakeholders who are providing services for our Black, Indigenous population and people of color. I'm also excited that we have a new Black Infant Health Director, Amira Thomas, who came on board with us within the last couple of weeks, and also Dr. Camilla, who is on maternity leave, and her role with MCH is she is our new doctor overseeing foster care services and also working with our California Children's Services vulnerable population. So I'm gonna go to the next slide and I'm gonna hand it back over to Maya to share a story.
Sure. I think I think we can skip over this and maybe go to the next unless there's any reason. You can read that on your own, because I did really want to focus on this story, because I sort of thinking about how do you receiving all this information, how do you then think about how that actually works for one client, right? And so this client is a 19-year-old first-time mother. She was referred to our field public health nursing team by San Francisco General's 6M pediatric clinic And just as background, when the pandemic started, in an effort to decrease the number of visits that women and infants were having to make in person in clinics, we partnered for some short-term visits to clients. And this was initially anticipated as a short-term, just go in and weigh the baby and make sure things were going okay. But as things turned out, the family had many more issues that needed addressing. And so she became a longer term client of ours. But the nurse went in initially to do a newborn weight check. And at that visit, in talking to the mother, she discovered that the mom had ongoing untreated pelvic pain. And so the PHN made an assessment and referred her back to the general, where the mom was treated for postpartum urinary retention. The mom also disclosed that she and her partner were unemployed and that they were experiencing food and housing insecurity. And this is prior to November of last year. They were very fearful of receiving assistance due to the public charge rule and potential impact on their long-term ability to stay in this country. So the PHN referred the mother to the Latino Task Force for food boxes and economic and rental assistance. The mom, as they got to know each other, said she had a goal of getting her high school diploma. And so the public health nurse referred her to a charter school where the mother was able to enroll and begin distance learning. And the mother was concerned because she hadn't yet received the baby's birth certificate or social security card, which she had expected to arrive in the mail. And so the PHN worked with the mom to reach out to those agencies and try to resolve those problems. Next slide, please. So this is a very typical case where on initial assessment, the mom denied IPV. But as trust was built, the mom started to share some challenges that she was experiencing. And the first thing she shared was that the partner had a drinking problem. And so the PHN provided some information about that and made a referral to Alcoholics Anonymous. But as the relationship progressed, the client revealed that for the last 3 years, the partner had been controlling and violent and had physically and verbally abused her, including abuse during pregnancy that left bruises. And she also suspects that he was taking documents that were sent to their address, like the birth certificate, and that perhaps the problem wasn't because they hadn't ever been sent, but because he was trying to control. And so the PHN worked with the mom to develop a safety plan that included providing resources for shelters, and then for planning for how to escape, which is what the mother did, first to the home of a church friend of hers, with a long-term plan of joining family out of state. So I hope that sort of helps you understand how these things meld. And then if you just to the next slide, Aileen and I were really grateful for your time, for your interest in our programs, and I'm just wondering if you have any questions.
Commissioners, any questions?
Yes, I have a couple of questions. When you talked about in the first slides, the sister program serving 480 families at a time, is that statistic where you're combining both the nurse family partnership and the field public health nursing?
Yeah, so currently, like as of this afternoon when I looked at the numbers, Nurse Family Partnership has 282 open cases and Field has 199.
Okay, so just because I'm also reporting to the rest of our group, so it's
Sure.
Nurse Family is 282 open.
Yeah.
And okay.
Field has 199. And that number will be higher because of deployments and vacancies. We are currently low.
Sure.
Yeah.
You did answer my question about languages. What is the communication referral mechanism to the other programs within MCAH? I know you alluded to it in the one of the slides, but is there a way you do it to make sure the family, let's say with the Black Infant Mental Health Program or the Black Infant Health Program, that they receive the referral, that the family got there and they're connected? I'm always concerned about referrals and the connections were made?
Yeah, that's a great question. Yes, we've worked really hard on that. So I appreciate the question. For both Black Infant Health as well as WIC. So all of our clients, we refer to WIC if they're not already on WIC. And we also have worked closely with WIC to ensure that clients stay on WIC. Many clients will sort of drop off as the child reaches a year old. And so we work to encourage the families to continue to receive those benefits because they are really great. Any client who identifies as Black African American is offered Black Infant Health Program, and we do follow up with the clients around that. There's also very nice coordination often between the public health nurse and the Black Infant Health social workers or nurses. Of course, with the client's permission, but it's quite synergistic actually. So it's good. It's good work.
May I also add to that your question? We also developed a tool. We did a PDSA, and what came out of that as a countermeasure is we developed a tool that is specifically, a referral tool, and it have all of our internal programs: Black Infant Health, Nurse Family Partnership, Field Public Health Home Visiting, WIC, where when we fill out that referral, you check off the box of services that you want the client to go to, and we also do. There's a follow-up, so we have also an internal form to make sure clients are receiving all of the resources that they can.
Great, thank you. I always find that's kind of the breaking point is with the referrals, and then great referrals, but then the follow-up. So I'm thank you for that information that there's a process. I also had one other question. When the client is to a point where they want to feel comfortable filling out that healthy relationship checkup form, is that in other languages or?
It's only in English and Spanish.
Okay.
Yeah.
Is there a possibility of having it in Chinese? Since
I think that would be great. Yeah. Yeah.
Right.
Yeah, I think it would. Yeah, that would definitely. I mean, currently, what we'll do is the nurse will translate it for the client if the client's, and we do have a number of Cantonese speaking nurses. But yes, it's always better to have tools in the client's own language. Yeah, no, that's a great idea.
it's just some of my work is at NEMS, and I know that this has come up a number of times.
Yeah.
And if it's the mom is Mandarin speaking, which makes it a little bit more difficult. It's just if the questionnaire was in Chinese, it's Cantonese or Mandarin, it wouldn't matter. It's the universal written Chinese.
Yeah.
So it's just a suggestion for the percentage of our population. I think it would be extremely helpful. And this is a population that it would be is even more difficult to admit to intimate domestic violence. So it's just a suggestion that
Appreciate
I
that.
think would be very helpful.
Yeah. Thank you.
It's a great program. You're doing great work. And I know I worked when I was on First Five. We had as well a partnership too with MCAH in the home visiting program as well. And you do wonderful work. And so thank you very much. And I'm thrilled Dr. Malawa is part of the team since she and I have been colleagues at Bayview Pediatric Clinic and also First Five. So great. And thank you.
And I believe Commissioner Chung has some questions.
I have to find the unmute button. Just two comments actually. Like one is I cannot tell you how much I appreciate your client profile to let us know how the program actually work and what type of interventions you offer. And that really helped us as commissioners to understand, you know, like some of these disconnections sometimes, you know, that we see is like we get a lot of numbers, but we don't exactly know how it improve people's life and improve people's health. And so I'm hoping that like from now on, you know, like everyone would like start profiling a client and let us know, you know, like how, you know, like how these success stories come about, and, you know, and let us celebrate with you. The second thing is not so much about the program, but I think that we also like annually, Mark, is that right? You know, that we get data on maternal death, mortality data on a yearly basis.
Commissioner, there's not, at this point, there's not a set time frame for any data. There used to be annual updates of each section, but each president of the commission kind of does things differently. So we haven't had that in the past couple of years.
Yeah, so that was one of the things that I am curious about is like, you know, I know that there's always, you know, the disparities, you know, in maternal mortalities and in the city. And so if there's a way that, you know, like when we have the presentations of this program and also at the same time, you know, like have some of those data, you know, like being reported, you know, so we can actually help to see if we can map out the trend, whether, you know, like we are improving or not. Does that make sense?
Yeah.
But overall, you know, the presentation was great.
Yeah,
And
no,
thank you so much.
No, thank you. I think you're absolutely right. And I think we have been challenged with our epidemiologist on this long-term deployment, and our analyst has been long-term. The COVID really has made all of our reporting, our data reporting difficult. But yes, absolutely. I mean, Aileen, I don't know if you.
Yeah, I appreciate that comment as well. I did reach out to our epidemiologist to see if she can pull any data that can give us any concrete information regarding a pregnant person who had had a bad outcome due to intimate partner violence or any type of violence within the last 10 years. And there was only one death related to homicide within the last 10 years. Our numbers are very low here in San Francisco. And also it's challenging right now to get really a lot data until we get connected to electronic records, our EPIC, and then we can be able to do more data reporting as well. So we just limited right now, but in terms of the outcome that you were stating, that violence is the leading cause for pregnant people, that number is very small.
Thank you.
And Aileen, can you give us a sense, and I'm sorry if I missed it, I'm asking on behalf of the commissioners, what's the timeline for y'all going on to EPIC? And are you part of designing your own components or modules so that it's going to fit your needs, like the referral stuff and those kinds of things?
Yes, we will definitely have the opportunity to design for the population that we serve, and we will be ramping back up the conversation, being able to be part of the process. We have a point person within our section who is a subject matter expert in, EPIC and also electronic records. So she will start back joining some meetings coming up soon within the next couple of weeks. But we probably won't go live, unfortunately, to the end of the year. So just a little bit away, but not that far off. So hopefully we'll be up come New Year 2022.
Thank you so much. And commissioners, any other comments or questions?
I have one more question on the relationship and I guess interaction and referrals with the child trauma research program. and the infant parent program out of the general,
Yeah.
and what the integration is, and in the referral, and how
Yeah.
you work with that that group.
We love to work with that group. We wish they had more openings for our clients. We work with them as much as we possibly can. And one of our NFP nurses actually went through a training program with infant parent program to become expert in that work. It was the first nurse that they had ever had go through that program. And so she consults frequently with our nurses around the infant mental health issues. But yeah, we work with them closely, and we just wish they had more capacity.
Okay, yes, no, two of my interns are there, so
Yeah,
that's
they're incredible. Yeah.
it's a fabulous program. So
Yeah.
I'm hoping that maybe their group also helps some of yours,
Oh, yeah.
train some of your staff as well, would be helpful.
Yeah.
Okay, so I think we're, thank you all for the presentation. I think, you know, it was clear, it was incredibly informative, and these programs are so important, but thank you for your great work. Commissioners, we can move on quickly to item 4, which is emerging issues.
Thank you.
Thank you.
Thank you.
Anything? All right, not hearing anything. We can move on to public comment, and there's no one on the line, so there is no public comment. So I believe we can consider, you all can consider a motion for adjournment.
I move to adjourn.
I second.
Thank you. That concludes the meeting then. Thank you both for joining.